Knowledge, training, and skills are clearly very important in improving the quality of healthcare. But as anyone who's been inspired by a lecture or training course knows, it can be very difficult to translate that into meaningful change in routine care. I wonder, Hilary, from your experience in implementation research, how can we facilitate change in practices?
Yes, thanks for that question, Linda, because in many ways, it's how I got into implementation research was the frustration of hearing something that I thought this would be good in practice, and getting back to my practice, and then the day job takes over, and you somehow never quite manage to get it to happen. And I think it was that sort of started my interest in implementation research. And then I read a paper by a colleague from the University of Aberdeen who did a really excellent teaching for asthma. I think they were mostly nurses, but certainly the person in the general practice that was delivering asthma care. And she gave them this really good teaching about delivering asthma action plans, consultation styles. They went back to the practice full of enthusiasm, and then somehow it didn't happen. And it didn't happen because the rest of the team didn't know the skills they got, because there was other things like the smear targets or the flu vaccinations that needed to be done, or whatever it was, and it just got driven out. So I really got interested in implementation, the research, and the more I read about it and the more I get involved, the more I recognise how complex it can be and how it really is a team effort. I can give you a couple of examples if you like.
That would be good. That would be great, yes.
Yeah. For example, if you want to deliver supported self-management, and that's the project that I'm interested in, and indeed Education for Health has been helping us with the educational aspects, you can teach the nurse or the pharmacist or the physiotherapist who's delivering that care in the practice about supported self-management. But if she goes back into the practice and then there aren't any action plans available for her to complete, and the practice isn't minded to get any, she's feeling flummoxed. How does she actually deliver this? Or maybe the GPs in the practice, and we interviewed some GPs, in fact, for the impart work, and they told us how, oh yes, our nurse does that. Our nurse is really good at delivering supported self-management. And we said, oh, what is it she actually does? And they didn't really know. So they weren't really in a position to support what the nurse had said because they didn't really know what the nurse had said. It's all about teams working together. That's just a couple of examples. There's many more where they come from.
I think that's really helpful, and I guess I'm minded as you were saying that to think about the push at the moment to reduce health inequalities and how we might use some of this to address that conundrum.
And because, of course, the people who will always get the help are not necessarily the people that most need it. So supporting the clinicians in the practice to sort of pull in the people who are at the margins of healthcare, who struggle to get healthcare, and the GP can do that. And guide that patient who perhaps is a little nervous of coming in or never quite manages to make an appointment, and actually guide them into getting the support by encouraging them. But you need to know what other people in your practice, other members of the team, are doing to be able to do that.
And I guess that's going to be a big challenge, isn't it, as we move forward with the new roles that are coming into primary care, like physician associates and healthcare support workers and so on.
And paramedics. And
Yes.
paramedics. Who goes out to the acutely wheezy person? In our practice now, it's the paramedics that go out first line. So they need to know about action plans and what the patient may have done, and encourage the patient. Oh, good, you did that. That's great. Now I can do this or that.
I wonder what some practical steps would be, what advice you would have to people who are trying to implement these kind of processes in practice.
I think the starting point for any change has to be communication and discussion, doesn't it, within the practice? There has to be a shared will to make something work. And almost always, I think the starting point is a discussion. This can work. We know that action plans, we know that supported self-management works. I'm keen to go on this course and learn about it, but I need to share this with you so that we can make it happen when I get back. And we don't just waste a couple of days of excellent training that never actually get into practice.
And with the elderly in particular, who are reluctant quite often to self-manage, what are some of the tips people could have around that?
The patients, I don't know. You see, I don't look at it like that, Linda. I actually see supported self-management. We are all self-managing all our conditions. Patients are looking after themselves all the time. They are all self-managing. I'm not with them every minute of every day to make decisions for them. So when they wake up at night wheezy, they're the ones that take the decision. Do they take more puffs of their blue inhaler, or do they call for help? They're self-managing. Now, they may not be doing it as well as I think they could, but they are self-managing. So I start from the premise that everybody is self-managing. My role as a clinician, and that's a role that we share as a team within our practice, but also wider with hospitals if they're under a hospital service. The role that we have is to give them consistent messages about how they can do it better.
That's a much more positive outlook, isn't it?
Yes, it's somehow you're not giving it. You're not giving it. You're not having to choose. Is this person? Can I give this person self-management? Just help them to do what they're doing better.
Yeah, that's brilliant. That's very practical as well, which is what people need, don't they?
Yeah. Otherwise, you go through a process of thinking: is this person for self-management or are they not? That never works.
Mm, mm. No, it's really good to hear that. That's great. So if there's one thing that you would advise anybody who's listening to do to support their patients with asthma, what's the very first step you would suggest to them that they do?
It comes back to talking again, doesn't it? And listening. Not just talking, but listening to the patient, hearing the issues they have or don't have with their asthma, and why they are doing what they are doing at the moment. And we all know that many of our patients with asthma, for example, stop their preventer treatment. Its adherence, we know, is very poor. So start from, okay, you chose to cut that down or to stop that. Can we discuss why that seemed the best thing to do? And not in a way that's judgmental, but just I'd like to hear why. And then we can say, right, okay, now let's move on and see what we could do that might be different. What are the pros and cons to doing that? Listen to the patients and work with them and be patient.
Patient is patient.
Yes, the clinician needs to be patient because my experience is that I've encouraged patients to take their preventer medication regularly, and it's water off a duck's back. They're not taking it in. It's not right for them at the time, and then suddenly they'll, after a bit of explanation, after maybe 2 or 3 years has gone by, a few acute attacks, they'll say, "Do you know, I'm wondering if I should take that regularly." You think, yes, yes.
And many clinicians will say when you're talking to them, but I only have 10 minutes for a consultation. How do they make the best of that 10 minutes? If listening is obviously key, but how do they make the best of that 10 minutes?
Well, recognise that there's maybe another 10 minutes that you can pick up the story in. We're not giving people a lecture for an hour. They're not going to remember it anyway. So what we're doing is we're nudging, really. We're giving them a bit of information pertinent to what matters to them now. Okay, so you're wanting to go on holiday. It's your first overseas holiday since the COVID pandemic, and you want to make sure you're well. Okay, let's talk about that. And then next time when I see you, or when there's an issue, or when, for a follow-up, maybe we can talk about preventing problems during the viral infection season. Don't cover everything all in one go. Build on what the patient wants to know now.
That's really helpful, thank you. And before we wind up this very short interview, I was wondering whether there was something around IMPART that you would like to share with people so that they understand where it is and what you're attempting to achieve.
I'd love to. IMPART is a program of work that we've been working on it for 5 or 10 years now already, but it is implementing supported self-management for people with asthma. We're trying to make it an implementation strategy that actually works in routine, ordinary, busy primary care. At the moment, we're currently recruiting practices for a trial. And if anybody is interested, if you look on the my name on the University of Edinburgh website, you will find a link to that you can inquire about it. But we're recruiting practices now to a trial, and we're randomising them. And one group will get the implementation strategy that includes an education module, the one that we've been developing, Linda, with Education for Health, but also resources for patients, but also organisational strategies that can enable it to happen in the busy world of general practice. And we're halfway through recruitment. It'll be a couple of years before we have an answer, but we're really hoping by taking this whole systems approach, we can actually make a difference to people with asthma.
That's brilliant. I'm sure there'll be many lessons from that can be shared across other conditions too. Brilliant.
Absolutely.
Well, thank you so much for your time this afternoon. We really appreciate it.
It's a pleasure, Linda. All the best.
Bye.